We're here to honor a person. We do this each year, as you all know. And this is our proclamation. You're free to read that. I won't read it to you. Instead, I'll tell you what the essence of this award really means. There are many people who have contributed tremendously to the field of cardiovascular surgery and the care of the cardiac surgery patient, medicine and surgery. However, the list becomes very, very short when you find someone who has lived their life with a sense of humility and humanity and has shared successes with those around them to help them achieve all of the things that they achieved, and have shown a true interest in other people more so than themselves. And that is a very short list, and it's a very difficult task to find the right kind of person that meets all of those criteria. Dave, if you'll put that slide up of our prior award nominees, I would appreciate it. Okay. Our past year's nominees, of course, Dr. John Ochsner. And I am so proud that he is here. He is the first person to have received this award, sitting here next to me. And we thank him very much for that. The second person, Denton Cooley, we saw that slide earlier, how important that was for him and Dr. DeBakey to reconcile. Just a kind gentleman. Contributed tremendously, but truly a gentleman. Dr. Ochsner and Dr. Cooley are best friends, and they both are just tremendously wonderful people, well deserving of the award. Dr. Len Bailey, we're going to, of course, hear his talk. We've heard a lot about him. We've met him before. He's given talks here. He was our third-year recipient. And then Dr. Mike Mack from Baylor. Of course, another person, Dr. Francis Robacek, incredible person. You remember him, said when you get very old, you become very awardable. And with that Hungarian accent, and of course, that's not to say, Dr. Brodman, that you're looking that old, but you know, you do have to live a while to earn this. And then, of course, last year, Dr. Watts-Webb, water skiing at 96. But just all of these people, just tremendous people, human beings. Very talented, and people that you would just like to hang out with. Wonderful people with wonderful stories that really care about their fellow man at every level. With that said, that brings us to Dr. Brodman. He meets all of that criteria and then some. I had an opportunity to go to Maine to humbly ask him if he would accept our very humble award, and he did so very graciously. And getting to know him on a personal level just reinforced and made me feel that much better that there was no doubt in my mind he was the right person for the 2016 award during our 10th year anniversary. We also have the privilege of having Dr. Blitz, who y'all know very well, was actually trained by Dr. Brodman, and he is going to say a few words. Dr. Ochsner is going to say a few words. He's going to receive the award, and then Dr. Brodman will also give us some vignettes. Seated next to Dr. Brodman is his wonderful daughter, Alexandra, who came here to support him and to be with him during this time. Thank you all very much. Dr. Blitz.
I'm going to keep this brief in the fashion I know characterizes Dr. Brodman. I have known Dr. Brodman for half my existence. Dr. Brodman has achieved tremendous milestones career-wise, and on a personal level, he's meant probably more than any other person in my career that I have encountered. He is extremely unique among the cardiac surgical brethren. Dr. Brodman, typically every year where I trained, had a bevy of surgical residents who were anxious to work with him, to learn more about the field, to get familiar with all the routines, to follow him in the OR, and to do research with him. I'll give you, thankfully, an anecdote that he's probably forgotten. My first encounter with Dr. Brodman was as a second-year medical student while I was rotating through cardiac surgery. In those days, we didn't have the fancy blowers we have now. I was up at the chest, very quiet, and my job was to put some irrigation on the coronaries during the distal and to suck up the blood. Very first case, very first procedure with Dr. Brodman. During the first distal, my suction catheter suctioned the whole vein into the catheter. Probably shouldn't remind you. Briefly, succinctly, unemotionally, he said, took the Yankauer, separated it, took the vein out from the Yankauer. There will be no more suction during this case. Thankfully, my subsequent experiences with him were much more positive for me and for him, hopefully. He really was a mentor to the whole group of residents and students who worked with him during the course of my medical school training and surgical residency. I worked on many publications with him. My first case report was with Dr. Brodman, who was the first person to report doing a maze procedure on someone in their 90s, which back then was quite rare. I also worked in the lab with him. In my program, we took our third year of surgical residency. So here I was, a resident who had just learned how to do hernias, open cholecystectomies, and I spent 4 months in the lab, somehow graduating to doing cardiopulmonary bypass on dogs, testing out the maze procedure. It was typical of Dr. Brodman to entrust his residents, to teach them, to have confidence in them, to give them confidence in themselves so they could accomplish what their hearts desired. After a couple of cases where we were not having the greatest of outcomes, came up to the dog lab, and we did a case, showed us how to do it correctly, and thereafter, he left the room, left us alone, said, "You guys can do this." And we sure did. Every other experiment from then on in went seamlessly. As meager surgical residents, we got to present our data at a major New York conference, in Nice, at the CardioStim conference, and then on in. When I was looking for a cardiac surgery position, my heart was set on going to UCLA. Dr. Brodman didn't hesitate. In fact, when I went to his office to ask him, before I even asked him, he said, let's get Dr. Hillel Lax on the phone. And there it was. In subsequent years, we've drifted in and out of each other's lives, I always following Dr. Brodman's career. He has always been a mentor, and any time that I had difficult decisions to make, I always sought out his advice. And typically as a mentor, probably about 10 years ago, Dr. Brodman was invited out to Japan to speak on his technique for radial artery harvesting. Dr. Brodman was one of the first people to re-pioneer the procedure in New York and had really perfected the minimal touch technique for harvesting the radial artery and had outstanding outcomes that he published. Because he was already senior in his career and felt that he didn't really need the accolades anymore, he called upon me and said, "Hey, how would you like to go to Japan?" And sure enough, he brought me along to Japan to present an analysis of the use of radial artery. And there it goes. I have met few people in my career in cardiac surgery who had that kind of beneficence to promote others, never feeling threatened, always willing to share. Residents knew that if they did a write-up with him, they would be first author, first and second author, always putting his residents first. And he has always been my model of what the true academic cardiothoracic surgeon should be. And I, hopefully, can achieve just a small part of what he has done in his efforts with me for the residents that I have trained and will train. So Richard, for me, heartfelt, I feel very fondly towards you. You have had a tremendous influence on both my career and my life, and I cannot think of someone more deserving of this reward.
Well, I was just told I was to make some remarks. And I'm really too old to make remarks. I'm very happy to just be here standing up. So my remarks will go straight to a joke. And for those of you who are not Louisianians, we have a particular colorful group of people in this state called the Cajuns. They speak a patois French, and they live in southwest Louisiana. And the story of Alphonse died, and he's sitting out in his open casket at the wake, and his three best friends are sitting next to him, looking at him and talking about him. And one of them said, Thibodeau, what do you want people to say when you're in that casket like that? Oh, he said, I want them to say, I was the best mayor this city ever had. When I was mayor, we never were in debt. And not only that, our football team won the state championship in 3 years. Now, I tell you, that's what I want to say about me. I said, well, that's nice. And they said, well, what about you, Thibodeau? Oh, he said, I want them to say about me, I said, I want them to say, I was the best policeman they ever had here. When I was here, we had no murders. Everybody behaved. Nobody stole anything. And it was just a wonderful time, and everybody was happy with me. And they said, well, that's very nice. And so then they looked over at Boudreaux, and Boudreaux just sitting there looking, you know. And they say, Boudreaux, what do you want them to say about you? And he looked and he said, I want them to point and say, oh, look, he's moving.
Dr. Blitz, if you'll come present the award, please.
So Dr. Brodman, from Perfusion International, the 2006 Achievement Award that you so well deserve.
Thank you so much.
Well, thank you all very much. I want to thank Vicki and Joe for traveling to Maine to meet me. We had a wonderful day together. I want to thank Perfusion International for selecting me and the program committee for seeing me as a member of a distinguished group of prior honorees. I'm really touched and amazed that I can be included with people of the stature of Dr. Oxner, Cooley, Robichek, and so on. I would like to make just a few remarks about my career and what it meant to me. I always felt privileged to be in the healthcare field with an opportunity to take care of others. And I was in a position to mentor young people like Ari, who is the best of the best for sure. And he learned his lessons certainly well. I felt that part of my job was to do continuous process improvement, which really means here I'm providing a service to patients, strangers, and how could I, as a clinician, improve the service that I provide to each patient, and how could I help some of my colleagues improve what they do? And that's really what mentorship and research is about. And for everybody in the healthcare field, you should feel that way every day you go to work and think about how you can better serve your fellow man. I'd like to give you a few anecdotes. In medical school, I rotated through the pediatric service. This was in the late 60s. And while I was on the rotation, a newborn was admitted with congenital chylothorax. That's a very rare condition where lymph fluid accumulates in the chest in a newborn that's otherwise perfectly normal. And the treatment at the time was the use of medium-chain triglyceride diet, and a chest tube was placed in one or both chests, depending on where the fluid was accumulating. And that treatment was really quite effective in most newborns with congenital chylothorax. However, some children with severe chylothorax that were producing massive amounts of chyle in the chest didn't survive that treatment. This neonate was a neonate with severe chylothorax, and the child was being treated using the standard treatment at that time and was continuing to lose weight on a daily basis. And every day when the child was weighed and losing weight, the mother became increasingly agitated. And over the course of treatment, the child continued to lose weight until the child started to look like it was starving. And people were starting to give up on this newborn. So I went to the library and I said, we must be doing something wrong. And I spent untold hours there working against the clock to try to find a clue that would give me some insight into what we could change that might result in survival of this child. I came across an obscure paper, and the paper was done in mice, and one of the findings was that if you don't give anything by mouth, you can reduce lymphatic flow in the intestinal tract much more than even putting water in, letting the animal drink water. So the next morning on rounds, I said we need a switch from a diet that's oral on this child to a diet that's intravenous. And the child was then put on total parenteral nutrition. And within 24 to 48 hours, the drainage completely stopped. And that child survived. I'll never forget the gratitude of that child's mother when the child left the hospital. Well, that changed the treatment paradigm for chylothorax. And a very few children who had severe chylothorax could then survive. Ari mentioned the maze operation. Jimmy Cox developed the maze operation and a number of other operations to treat rhythm disturbances. Remarkably creative surgeon, made massively important contributions in the field of arrhythmia surgery. The patient that Ari mentioned that I operated on had a combination of hypertrophic obstructive cardiomyopathy and atrial fibrillation. So when the patient went into atrial fibrillation, the heart rate would go up and the ventricle couldn't fill, and the obstruction in the left ventricular outflow tract increased. So the patient would go into shock. And the cardiology team had defibrillator pads on this patient, and they were trying all kinds of medical cocktails to try to control the fast AF, and were remarkably unsuccessful. And I was asked to see the patient to do this new operation. And we went ahead and did the operation, and the patient had a very, very, very rocky post-op course for 2 reasons. One, the patient retained massive amounts of fluid because the atrial natriuretic peptide, which is produced in the atria normally, which affects fluid and electrolyte balance, its production was impeded by the surgery. The other problem was the patient required permanent atrial pacing after surgery. And that patient ended up with a permanent pacemaker. And I wondered whether the operation was the cause of this sinus node dysfunction. And that was the experiment that Ari performed in the laboratory. There were 3 incisions in the maze, 1 operation around the SVC-RA junction, and Ari identified the incision that caused sinus node dysfunction following the maze operation. Well, Ari presented this work at the New York Society for Thoracic Surgery, and Jimmy Cox just happened to be there as the invited speaker. And after he heard Ari's talk, he went back to St. Louis and developed the Maze 2 operation, which eliminated the 1 incision that Ari found caused sinus node abnormalities. So that's an example of how you can improve the service to your patients, help a colleague by identifying a problem. The last thing I want to mention is the use of arterial grafts for coronary bypass surgery. When I was a resident, the grafts that were used where I trained were all vein grafts. George Green had published already the routine use of the internal thoracic artery for coronary bypass surgery, and I went to work with him for a month in 1979 and scrubbed with him on 32 coronary bypass procedures. He was unusual. He used an operating microscope to do coronary bypass surgery. Very, very, very few surgeons used an operating microscope. And the power of the scope that he used was 5 to 15 times. That was much more than most surgeons at the time were using for optical magnification. One of the benefits of using the microscope is that you have ideal visual conditions upon which to look at the microsurgical anastomosis, because for a variety of reasons, the optics are better, the lighting is better. Also, as a surgeon, you're standing with your head straight, so there's much less strain on your neck, so you're more relaxed when you operate. Also, when you do an anastomosis with an artery to an artery, it goes quicker because you don't have to sew a big, huge vein to another vessel into the side. I think one of the reasons that it didn't spread as rapidly as it should have was that George was using a microscope. And probably surgeons felt that, well, you know, if I got to learn how to use the microscope, I don't want to use the internal thoracic artery. The other reason probably, which is common, is that people resist change. Well, I went back to my institution and I started using the internal thoracic artery. And after a number of years, I would see some of my patients back with malignant progressive atherosclerosis in the veins. And other surgeons were looking at other conduits to use, as well as the arterial conduits to use. And so I started looking too, because we're doing performing an open heart operation that is good for 8 to 10 years. an operation that's has more progressive malignant atherosclerosis than the disease you're treating in the patient's native vessels is not a very good operation. So I went through, tried a variety of different vessels and arterial vessels, and finally decided that the radial artery was a vessel that might be useful. But to be useful, it had to be available in the vast majority of patients. So we spent a year trying to figure out the technique for harvesting the vessel and what method to use to assess the adequacy of collateral circulation to the hand when you took the radial artery out. And after we figured these things out, we then started on a clinical program. And I used bilateral radial arteries in over 50% of my patients. And 92% of the patients that I operated on got arterial grafts. 92% of the grafts I did in patients were arterial. Only 8% were veins. And the patency rate was well into the mid-high 90%. And that operation I continued to do unchanged throughout the remainder of my career. And I never had to reoperate on any of those patients. And when some of the patients came back to get recast, it was very, very common to see the radial arteries pristine, like the day they were put in, but the patient's own disease process in their native vessels had progressed. So it was a better operation, and in the words of one of the patients that I operated on at the age of 86, he sent me a thank you note a number of weeks after his surgery. I did 5 arterial grafts on him. He said, "I want to thank you for thinking of my long-term welfare." So I want to close with that remark, and again, thank the committee, thank Dr. Oxner, thank Joe Basha, thank Ari Blitz, and thank the planning committee for this distinct honor. I'm really touched.